everyone, good evening. I'm Melisa Idris. Welcome to Consider This. This is the show where we want you to consider and then reconsider what you know of the news of the day. With Malaysia's medical inflation hitting 12.6%, the rising cost of healthcare has become an urgent concern for both policymakers and patients alike. Is it time for a radical overhaul of how we manage healthcare costs? Joining me on the show to discuss this further is Professor Dr. Sharifa Ezat Puteh, Professor of Public Health Medicine at UKM's Faculty of Medicine. We also have Public Health Medicine Specialist, Assistant Professor Dr. Farhan Rusli. Both of you, welcome to the show. Thank you so much for joining me. So let's talk about that medical inflation at 12.6%. There are some experts who say it's cause for alarm, others dispute. They say it's not that big a deal compared to the region and the global average. But when you look at the trajectory of Malaysia's healthcare costs, where do you see it going? What's your assessment? May I start with you, Dr. Ezat?
Yeah, thank you, Melisa, for having me. It's true. I think globally the cost of healthcare is increasing everywhere. It's a global phenomenon, and there's many reasons for that. I think all of us know about the cost of non-communicable disease, aging population, the burden of new technologies, and so forth. But also the consumption from the population itself. So we are facing a lot of issues with healthcare costs. We don't have enough manpower, and this is evidenced by what we see in the emergency department. Some of the issues with the patients waiting queue for operation time, for clinics, and so on. The issue is that one of the issues is that the inflation of medical care is always higher than the cost of inflation per se. So if you look at the CPI, the cost consumer index, price consumer index, the inflation cost for the whole Malaysia would be roughly about 2%. But for the healthcare cost, if you look at 2023, it has gone up to about 15%. So that shows how much inflation of healthcare has increased. Now, our total health expenditure has always been on the rise, and most of these are provided to the public, hospitals, clinics, and so on. The hospital will have a bigger budget compared with the primary healthcare and also the preventive medicine, things like the clinics and so on, which is an issue by itself. But of course, healthcare is very happy because we receive amounts of the second highest from the government, and that's good. It has always increased year by year. If you look at some of the high-income countries like OECD countries and so on, the percentage that they use for their healthcare would be around 7%. That's an average. But Malaysia, we always use about 4 to 5%. Not more than that. So it has always been relatively low.
Yeah. and underfunded, right? So people say there's underinvestment in the healthcare percentage to GDP.
Correct. So that leads to some of the issues that we see now at present. We have all these issues, so that can be relatable to that. So what is the end game? If you look at some of the data from, let's say, out-of-pocket payments, so this is something that we really don't want people to pay out-of-pocket because that is what we call as regressive financing. And the cost of the out-of-pocket has always been increasing. And why is this happening? Even though Malaysia, in a way, we are what we call as a universal health coverage. That means, by WHO standard, this is a country where we should be, having sort of finance coverage for everyone.
Right.
The population coverage would be high, and everyone, in a way, will be protected from catastrophic health expenditure, meaning that you have to fork out a lot of money for healthcare. So Malaysia is supposed to be that in the Universal Health Coverage Index. If you look at some of the index, we are not that low, meaning that we are not that bad. We receive a lot of investment, but of course a lot of recognition as well. But this is not enough.
Just a quick follow-up about the out-of-pocket expenses. So Malaysia's out-of-pocket expenses is significantly higher than the WHO recommendation. I think we're double, like 30% based on compared to WHO 15%.
Exactly. So why is this happening?
Why is that?
Exactly.
I don't quite understand.
Yeah.
Why does that happen? Why
so
are we
if you look at some of the ratios
so
of health expenditures, most of this would go to the public for out-of-patient, but about 40% for outpatient care would be to the private. And the same, so that is also for inpatient care, where inpatient care, most of this will also go to the public. A bit will be to the private, but outpatient, most of this will be going to the private because private access is easier and things like that. So, which is a bit perplexing because you will see that the out-of-pocket is always increasing year by year, and we don't want it because we want to protect our population.
Understood. Okay, Dr. Farhan, let's bring you into the picture. When you look at the healthcare costs, are you concerned?
Of course, we're concerned, but I think we have to expand on what was being said on the other pocket and all these things, because there's a good relationship if you look at it. So if you see how we are spending more out of pocket, you start to question yourself, why is that so? It goes back to your basic fundamental question just now. Why is inflation increasing? And is our spending actually enough? So if you look at the budgets from 2020, 21, 22 and all these things, save for COVID because it was a special budget, you see that we have an increase in the amount of budget that we spend per year. But is it 15% more? When you say yes, there's 15% more, that's just to give you the same services that you had the year before, taking into account inflation. So you're getting the same service. There's no improvement in the healthcare system here. So that's why you have to catch that. So even though the budget is increasing, but are you actually improving the healthcare delivery? So if you say that, yes, every year we will match whatever is the healthcare inflation. So every year the Ministry of Health budget increases by 15%, for example, which they don't anyway. So, or 20%, regardless of the inflation. But when you do that, you only give them back the same type of service that you had the year before. You're not spending more or improving more. You're just keeping up with the cost of healthcare. So when you do that, what happens? When you do that, you have the deterioration of the public health service, and you have people moving towards the private sector, especially for outpatient care, because nobody wants to wait 2 to 3 hours just to see a doctor for a common cough and cold, and they move towards the private sector and they go to the private clinics. And in private clinics, they spend more, and that's why you have a double of the WHO average. So if you look at those type of statistics, when you want to tackle healthcare inflation, it's not just about what can we do, should we reduce this or should we spend more? No, you have to look at it like what healthcare is. It's from cradle to the grave. It's extremely important for you to look at the basis of why healthcare inflation is actually on the rise, why Malaysia is heavily impacted by this, and what we as a nation can actually do to actually improve and reduce or mitigate the inflation effects to our healthcare industry.
Okay, I want to come back to that, but let's talk about, say, the patients who migrate to the private healthcare sector because maybe the public healthcare sector is overburdened, right? When we think about the kind of public-private partnership in the healthcare sector in this country, what role do private hospitals play in terms of healthcare costs and medical inflation?
So that's the thing, right? I think for the past 30, 40 years in Malaysia, we've always looked at healthcare as between public and private. Yeah, we've talked about public-private partnership, but if you actually want to move as a nation, you want to move your healthcare into the next level, to up your healthcare service delivery, you have to look at the totality of healthcare, which means that public and private has to be seen as one. You can't break it up. You can't say that, oh, we are public, we only take care of the public hospitals and all these things, we are going to forego the private hospitals and all these things. No. You have to look at where the big numbers of doctors are. The big numbers of doctors are in the GPs, right? There's a lot of GPs compared to the doctors that's in the public health, primary care centers, clinics, kesihatan and so on in the country. So why not we maximize and utilize? Because what is your end goal? Your end goal is to ensure that Malaysians get access to healthcare. Why should it bother you where they get the healthcare from? Is it from a private GP or from a public medical officer? If you can maximize and utilize primary care and use private and maximize their utilization rates, then you can actually start moving these medical officers from these primary care clinics into hospitals where I'm sure you have heard not enough doctor, not enough MO, not enough of this. Then you can actually start to solve you're right? We have to look at them as doctors, regardless they are private or public. These are things that you have to think about.
Right?
Yeah, I would want to introduce one concept to the listeners and viewers, but also maybe to Melisa that, we just had our the white paper healthcare reform, and that has been mooted by the Ministry of Health together with a lot of experts coming in from the private, from the public, Pesara, our ex-DGs, and there's so many experts that are looking on those areas, including opinions from abroad. So the white paper proposes, a new type of financing, as what has been mentioned by Farhan, is that so this solidify the relationship between the public and private through a new financing method, what we call as the social health insurance. So when you have something like a social health insurance, let's say I'm a patient or a population coming from the population, I may be from the B40 or the M40 and things like that, which has been hindered by the private sector because I cannot access, I don't have enough money to pay. With this insurance and some premiums, some benefit packages and things like that, I'm able to access the private sector as well with some sort of card or things like that, eligibility card. I'll be able to access my services from the private sector, and this is paid through a pooled fund managed by the government. And this is something like what we call as the social health insurance. Now, for the T20 people, or basically the high-income population, they can be better protected, meaning that they can opt in for the social health insurance. It has to be mean tested, meaning that when you go in, you have to really check whether you are really able to pay and things like that, because we don't want people who are, high income but they are abusing the system.
Right.
So we want these people who are the T20s and the higher income, they can also be extra covered by another insurance, which is the private health insurance or the voluntary health insurance. So in a way, you will have two separate insurance systems. One is covering for the middle and low income population. Another one would be added on with another so-called private health insurance for the top level population. And the premiums that they pay can be very different, meaning that for the people covered under the country's social health insurance, the premium will be very low. And most of these will be either covered by the employer, it can be covered by the state as well.
Right.
And they don't have to fork out their own money, meaning that the poor will still be protected.
Right. There's some way of kind of targeted assistance for them through this.
Exactly.
So
the higher income would be, because they have money, they will be paying on their own.
Do you envision the role of the role of private insurance to change in the future?
For private insurance, if they are really in general, private insurance, most of these are for profit, and they are looking at premiums, and these premiums are not cheap. It is quite, high. It is quite high. They have very high deductibles. Of course, it depends on the coverage and so on by insurance. And the private health insurance in general, they will be looking at the higher income but the low risk population. And this is what we call as skimming the milk and things like that, getting the high income population. So this is something like a moral hazard. Now, in countries where they have actually taken up private health insurance in a big scale, things like US and things like that, the outcome of the population is not very good. Because when you have private health insurance, I'm not saying that private health insurance is bad. Of course, it's good, but these are only accessed by certain people who are able to pay their premium. That's the problem. Now, what about the middle level and the lower level? They have to be covered either by the employer. So let's say I'm an employee of, let's say, Celcom or, Maxis or what. So my boss will sort of pay for the insurance premiums and I am covered. But not many people have that luxury. That's the problem.
Yeah.
So they have to be covered through something where the premium is covered by the government, and there can be some sort of pool. So this pool can be actually can be used to pay the premium for the social insurance. It's going to be very low.
Dr. Farhan, what do you think about this?
I think that's why moving forward, the hybrid mechanism is extremely important. I mean, you cannot blame a business for acting like a business. I mean, you ask any insurance company, what's your main end goal? I mean, they can say whatever they want, but it's making money. And you don't blame businesses for wanting to make money, right? You don't blame them. So I think that option, if given to anyone who wants to opt in and buy those type of insurances, can go ahead. You can cover yourself with whatever amount that you need. But at the same time, you have a safety net where people who are unable to actually get this sort of premium still get access to the same type of high quality healthcare through a more better plan or more better financing package, such as the universal healthcare coverage or the social insurance, where people pay what they afford to pay. So let's say if you cap it at about 5% or a minimum of 50 ringgit a month. So because like how you see how we did the diesel subsidy rationalization and all these things, for those who are even unable to afford the $50 a month, the government can pay and cover for them. For those who can, they can pay the $50. For those who have income of maybe 8,000 or 10,000, they can pay up to 500 ringgit. Why not? So, but what I'm trying to stress is that when you talk about healthcare delivery, healthcare inflation, insurance, and all these things, what is most important is that you should not have a distinguishing healthcare delivery quality regardless of what level in society you're from. So you can't say that the best type of healthcare is only available for those with the high premium groups. The low premiums get to wait 3, 4, 5 hours. You can't do that. So you have to look at everybody as equal. Health looks at everybody in equality. So how you want to bridge this gap is through what has been mentioned by Prof already. You have to have this sort of hybrid mechanism. And in these types of things, you reduce the burden to the government itself that they have to fork out and pay for everybody, you know, and
Right.
it becomes abused by those who actually can afford premiums.
So this is on the health white paper, as you mentioned, Dr. Ezat, and you know, healthcare financing has been discussed many times before, has been attempted many times before, but we've seen very little radical change on that front. In the meantime, we have mandates like the one from Bank Negara saying that you have to have copay in all new insurance products going forward. That seems to be kind of small diversions as opposed to the structural reforms that you alluded to. So how do we think about that? How do we think about, you know, where the country is heading versus what we actually need to do to get the healthcare financing sustainable?
Well, it is a government policy. It has to be forwarded by the government. Of course, the government, when I say government, it involves a lot of ministries, including, I think the most dominant would be the Ministry of Health and the Ministry of Finance in these areas as well. And if you're talking about the low-income population, which we refer, you know, generally as the B40, a bit of the M40 and things like that. If you're talking about the co-payment, you know, I think this is...
Is it a good idea? Do you think it's a good idea to have all people, in the future, maybe all policyholders have a co-payment feature? If you look at some of the
research, Melisa, if you look at some of our research, our research, maybe we have done research after research on this. The amount of payment that we actually pay at this point in time to, let's say, the clinic kesihatan or the public hospitals is actually relatively very, very low. Most of these are subsidized by the government.
Actually, most people don't know, right? It's RM1 or
yeah,
5
correct. Yeah, RM1.
Yeah.
You know, specialists like RM5, sometimes RM30, which is very, very minimum. So that we have done studies, local studies that shows that a lot of people are actually accepting higher amount to pay for healthcare, even though the clinic kesihatan, they are eligible to that, meaning that they are willing to pay. But for inpatient care, which is sometimes more expensive, you know, not many people are able to afford more to pay for inpatient care because, especially for the B40, we're talking about the low income, the B40 and a bit of the M40, they are not able to pay more. So when that happens, if you impulsively, you know, make it a policy that they have to pay some sort of co-payment, that would be a deterrence of people to access healthcare. That's my general opinion. This does not matter if you are the T20. That's why the mean testing, or basically assessing your level of ability to pay and willing to pay, is different. For the T20, if you impose a co-payment, that is fine, because a co-payment means that you have to you know, pay a certain percentage of whatever healthcare service that you obtain. Let's say the charge for your operation is 2,000, you have to pay, let's say, 210% out of that. The T20, I think this is no problem. For the B40, I think we cannot do that. For the M40, again, you have to test it person by person, family by family. Different household will have different difficulties and so on.
That sounds very complex.
Correct, but they are already doing it in some other countries. We should probably do the same as well.
So you see co-payments as needing exemptions, as needing...
Some, yes, they would need exemptions as well, because even for the M40, which we say as M40, they may have disabled children. They may have, you know, only one person working for the whole family.
Right, every household is
because
different.
you don't want to price out people from healthcare. You don't want to price people out.
So are you concerned that
yeah,
co-payments might lead people to delay seeking treatment, delay seeking healthcare?
Yeah, even I
Yes.
think within the M40 groups, even if they have to pay RM1,000, I think the studies done by BNM and said how many people actually have access to RM1,000 immediately, and you'll be very surprised, and you'll be very also surprised that not a lot of the Malaysian public actually have access to credit. So if you tell the T20 pay up 1,000, they're not going to pay up 1,000 cash. They're going to put it on their credit card. They can even have their 0% payment plans and all these things, and it doesn't hit them at all, even though they can actually fork out the 1,000 cash. But for some, knowing that they might have to fork out the RM1,000, they may not even seek that treatment and just go for other options and all those things. But I think what I would like to draw, Melisa, is that when you talk about healthcare inflation, because that's a big topic here, right? You're talking about cost of healthcare and all these things. Actually, I think everybody has been looking at it from, I believe, in my own opinion, that it's actually in the wrong angle. We've actually not been looking at healthcare. All this attention that we're giving in is actually to just sick care. When you talk about healthcare, you're trying to promote a healthy lifestyle, you're trying to promote people to not get sick.
Preventative care.
Preventative care, but everything that we've discussed, every single thing that we've talked about has only talked about how to treat people. So you talk about the aging population, you talk about people coming in. Why is Malaysia so worried about an aging population? Because they think that there's going to be a rise in the cost of sick care. But what you should be thinking is that why is everyone who's getting old getting sick? Why is places like Japan, they have one of the highest numbers of people who are old, an aging population, but they don't have a burden in the healthcare system?
How do you think we approach preventative care in Malaysia?
Very simple, we don't.
Okay.
Right? We don't.
So policymakers don't see this as a need or a priority?
All right, when you look at the medical budget, how much of it actually goes to pharmaceutical products? 80%, 85% goes to actually just buying drugs and all these other things. That actually just shows you how much of money you don't spend on public health, you don't spend on actually preventative care. But again, I want to stress the point that people always think that the custodian is the Ministry of Health. If you want to talk about healthcare, it's a game that involves everybody.
Sure.
You're talking about childhood nutrition. Right now, Malaysia is being hit by a triple burden of disease. You're talking about stunting, obesity, as well as anemia in kids. And these things, in 20, 30 years, will show that it's going to actually have a very high impact on how you have healthcare system deliveries, because you're going to have more people who are sick.
Money is not made through people being healthy. That's the problem. Money is made when you are sick and you are able to buy or obtain some treatment or things like that. And this is, I think, a knowledge of most of the big pharmaceutical companies in general. I'm talking in general. I'm not saying that which company, but in general, this is where we're heading. Getting more vaccines, getting more drugs, getting more sort of treatment. When we can stay healthy as much as possible, you need the self-care. You need to maintain your own health as much as possible. Delay your onset of diseases. Now people are getting diabetic, like when I was young, people get diabetic when they are 60 or 50. Now people get diabetic when they're 20 and 30.
Yeah, correct. Because touching right on that point, this was not pre-discussed, of course. How do you tell a nation, please be healthy, at the same time, I'm going to subsidize sugar? So what notion does it bring from policymakers, right? You subsidize prices of sugar, refined sugar, you subsidize that price. At the same time, you tell them, please get healthy, please don't get obese, please don't do this. In what mindset do you tell someone, this thing is dangerous for you, I'm going to provide it for you, but I'm telling you, please don't touch it. So these sort of things requires buy-ins from all levels of government. And you have to understand that a healthy society is a very productive society. You want to talk about increasing GDP and making Malaysia to be a nation that is an economic powerhouse. Deal with the healthcare. You want to talk about how you want to actually grow and make our country better? Deal with the healthcare. Because if you don't, you're going to go down the drain. And I think it's a high time that the people who walk in the corridors of power understand the need that healthcare reform is inclusive of financing, public health,
urban environment, natural environment.
Correct. You tell people to be healthy, you don't provide them with enough parks, you don't give them cycling lanes, you tell people to exercise, but your gyms are out of shape. You tell kids to play outside, but
there's no facilities.
Or it's not safe.
The playgrounds are not safe, there's no policing around. So you must understand, when you talk about healthcare inflation, it's not just about how much it's going to cost. You have to talk about why it's a problem in the first place. And if you don't address those fundamental issues, you're never going to get anywhere.
So these are what we call as the social index or the social health determinants. Simple things like education, clean water, safe environment, good air quality, and all of this, again, it has to relate with the government's policies. So these are social things which is very simple, like presence of police, a good education and things like that, clean water, good environment, but if it's not there, it will also ruin your track on a good healthcare system.
Right.
Correct.
So really, I mean, I guess I've been looking at this from really kind of dollars and cents perspective when we think about healthcare costs, the demand on healthcare services and the supply of healthcare services, sometimes supplier-induced demand. So when we think about, both of you, what you're telling me today is that you have to think about medical inflation, healthcare inflation as a bigger, broader topic and not just look at it from the monetary perspective.
Correct.
I'm sure we could talk about this for many, many more hours. But again, this has been quite an enlightening session. So I thank you both for your time. Appreciate it.
You're most welcome.
That's all we have for you on this episode of Consider This. I'm Melisa Idris, signing off for the evening. Thank you so much for watching and good night.